So, hi to everyone who is going to listen to this podcast. I'm Artin Madanian, a board certified psychiatrist, currently based in Washington, D.C., but I practice both in DMV area of the US and Quebec and Nunavut in Canada. I did most of my training at McGill University and had the privilege of working under supervision of Dr. Gerald Wiviott that I will introduce soon. And I got introduced to existential psychiatry during my residency. It resonated much in me in after my graduation from fellowship and my practice. So I got to use the uh, knowledge of Dr. Viviet in the past 2 years doing mentorship in my journey in learning more about existentialism. So today's podcast goal is to talk about briefly about existentialism, existential psychiatry, and know a little bit more have a little bit more knowledge for people who are interested, especially people in the field of mental health, residents, psychiatrists, and psychologists. So, Dr. Gerald Viviot, can I ask you to introduce yourself?
Yeah, I'm Jerry Wiviott. I like to use the Jerry as opposed to Gerald. And I am a retired psychiatrist who spent my professional career in Montreal, trained in psychiatry at McGill, and then when I went on to stay on faculty at McGill and worked in one of the major teaching hospitals, the Allen Memorial Institute in Montreal, and I've enjoyed my career.
Okay, great to have you with us, Dr. Viviet. And I I should say that I'm really grateful to our, sessions in the past 2 years, you mentoring me. Now, can you tell our audience, Dr. Vivians, what brought you, what career path you had that drew you to psychiatry and then specifically existentialism and existential therapy?
I thought you were going to ask me that, and that was something that made me think a lot because I hadn't thought about that before. But when I thought about it, I realized that in order to understand how somebody becomes a psychotherapist, but particularly an existential therapist, it's important to look at the life experiences that they've had, which in some ways may be more important than the traditional pedagogical formation that leads to people becoming a psychiatrist or even a psychotherapist. So I need to tell you a little bit about what I've gone through. And I want to start with undergraduate work in the University of Wisconsin, because I am an American, also a dual citizen. I'm Canadian. But I went to undergraduate school at the University of Wisconsin, and there I wasn't sure what I wanted to do, but I took an introductory philosophy course and I was intrigued and wanted to go further in philosophy. And then I took a existential philosophy course. And I remember the first lecture, Dr. Eugene Kalin, who was professor of philosophy, went up to the podium in a large auditorium. And the first thing he said, and I'm not going to use the word completely, but he said F you very loudly. And he then said, anybody who can't tolerate that language should leave now. And of course, nobody did. But I thought that that shocking beginning and the sense in which he was not inhibited was very moving for me. The openness in which he addressed people, and that went on through the rest of the class. And in that course, we obviously read um, works by Camus and Sartre and Kierkegaard, and also Samuel Beckett, who had a big impression on me, Waiting for Godot, Malloy, Murphy. And these books made me think about life in a way that I obviously wouldn't have thought about life before. So I had to tell you that. And then something happened where I applied to medical school at Wisconsin, but I met a friend who uh, had a friend who was going to medical school in New York, and he said, "Why don't you apply to New York?" Which I did, and I was accepted there. And that was a big change in my life, living in New York City for 4 years. Um, and it wasn't the right fit for me. It was too science oriented, and as I say, I came to it with a degree in philosophy. Um, and I struggled in medical school. Um, I remember my first rotation in psychiatry, and the teachers there were primarily psychoanalytic because this was in 1965, 66, and they were mostly psychoanalytic, and it just turned me off. The sense of rigidity, the formality, the idea that everything could be explained by looking at defense mechanisms, etc. And I thought, you know what, I don't think I can be a psychiatrist, even though when I went to medical school, that was certainly high on my list.
Mhm.
And then I was very impressed with the professor of surgery. And in my vocation as a medical student, people said, "Oh, you have, good hands. You could be a surgeon." And so I decided to go into surgery, and my internship was in surgery. And after 6 months um, in surgery, I was called in for an evaluation, and they told me that I was spending too much time talking to patients. And I knew then that I couldn't stay in surgery. Now, the important part is that when I was in surgery, don't forget, this was during the Vietnam era, and I had a 5-year exemption from the Army while I finished my surgical residency. But as soon as I decided to leave surgery and go into psychiatry, I lost that exemption, and I thought I was going to be drafted. And I was very anti-war, as most of my colleagues were anti-war. One thing that happened during medical school was a a younger doctor had gone to Vietnam as a physician, and he came back to speak to us, and he told us about how you could be anti-war and still do the kind of work that you need to do as a surgeon, a battalion surgeon. That's what it was called in Vietnam. In any event, I found out that there was a draft exempt position in Texas, which I took. So I went to Texas, I worked there, but my draft board in Wisconsin said, we're not going to honor that exemption. You're going to be drafted. And I had to call McGill and apply for a residency because I was going to leave Texas. I was going to leave the States. I was going to be a draft dodger. I was going to go to McGill. And I had applied before to McGill before I went to Texas, and they accepted me for the residency program. But okay, I went to Texas, and now I'm accepted at McGill, and I am driving from Texas to Montreal when I don't know what to call it. It was some kind of crisis where I wondered, why was I doing this? Why was I going to be a draft dodger? Go to, and then I realized it was because I was a coward. And I didn't want to live with myself being a coward. And so instead, I went to Milwaukee, where I was inducted, and I served a year in Vietnam. And while I was in Vietnam, I wrote to McGill again, and I said, "You guys aren't going to believe this, but I'm applying again to your program," and they accepted me. And I have to tell you, that was the most important decision of my life to um, both to go to Vietnam because it was an existential question. It forced me to look at choices, responsibility, and the freedom to make choices. Yes, in retrospect, that's what it was. Um, and then, of course, the decision to go to Canada was huge. So I started my residency, and it was a wonderful experience. And I'll tell you why it was such a wonderful experience, because in this period, in 1970, 71, 72, we would have conferences, a case presentation, for instance, and the psychopharmacologist would say, "You got to give this person medication." The psychoanalyst would say, You have to go to the bottom of the problem and figure out the root of the problem. And the behaviorists, of course, would say, well, this is simple. All you have to do is give these kinds of directions and people would get better. So as a resident, it was an exciting and intellectually stimulating time. But during the course of my residency, I worked on inpatient service and consultation liaison service and had some wonderful supervisors. And one supervisor in particular, um, and this is before I was interested in existential, even I think before I knew what existential therapy was, but I was working with a patient, and this young lady was doing quite well in therapy. And then she said, I have a problem and it's going to require heart surgery. And so I think we should stop therapy. I can see you for 2 more weeks and then we have to stop. And my supervisor, Dr. Eric Whitcower, who I'll never forget, said to me or asked me, do you like this patient? And I said, yes. And he said, have you told her? And I said, of course not. And he said, you should. And that just opened up all kinds of possibilities. Instead of that more rigid framework, the more psychoanalytically oriented framework, which I had been trained to do, Dr. Whitcower made me realize that I could be real. It was a humanistic form of therapy. And from there, he may have suggested that I look at the work of Irving Yalom, and I started reading some of the novels that Yalom wrote, Love's Executioner, When Nietzsche Wept, and the Schopenhauer Cure and stuff, and his textbook on existential psychotherapy. And I realized that this is the direction I wanted to go in. This where one is focused on the fundamental concerns of the human being. And as you probably know, well, I know you know, when he talked about how we have to look at people's meaning, how people integrate the notion of mortality into their lives, how they deal with the tension between isolation and connection, and how they take responsibility for the decisions they make. Given our fundamental freedom in the world, we're constantly making decisions, even though we don't realize that we're making decisions. So all of these things affected me and led to my pursuing existential psychotherapy as a way of working with patients. And for the next 40 years, I guess, I would say that I was working on this existential model. But let me add one more thing. Self-psychology also played a role in my training because I did have supervisors who turned me on to Heinz Kohut and the analysis of the self. And that offered a way of understanding empathy, which has to be added to the content of an existential therapy, the relationship that one establishes with a client or with another human being. I could say patient, but I'd rather say another human being, is a combination of both the empathic attunement as well as the issues that the people are dealing with. So let me leave it at that in
Okay.
terms of how I got to be wherever I am.
Mhm. Thank you. Thank you so much, Dr. Wiviott. I learned a lot about your life journey and how it drives you to do psychiatry and then uh, existential therapy. And I think we have been lucky at McGill University that life kind of drove you towards McGill in Montreal. Now, what I got from your stories, your life experiences and your worldview kind of shaped your interest into existentialism and existential therapy. I I wonder if your education later on or your trainings in existential therapy and existentialism kind of influenced your worldview on life as well.
Yeah, yeah. There's no question. Um, your question makes me think about something that is, I think, relevant. One of the keys to understanding existential therapy is how one participates in the relationship. And learning about things that traditionally have been called transference and countertransference. In an existential therapy, it's more about feeling the empathic connection between people. So certainly it's relevant in terms of my work with patients. It's also relevant in my work as a supervisor. But a real boost in that awareness came from working with couples. I had an opportunity and some very good supervision at McGill to work with couples and families. And I was part of a couple and sex therapy clinic for 20 years, even more opportunities to work with that triangular relationship, the therapist and the couple. And so I could understand the dynamics between the couple, but it also helped me understand the dynamics between me and whoever I was working with. And I didn't want to limit it to transference and countertransference, which I find rather cliche terms. I wanted to think about it in terms of who is experiencing what? What was I experiencing? What do I imagine the people that I was working with, what were they experiencing? And certainly that is what we think of as empathy. But again, I don't want to limit it to the cliche. It was this gut feeling about what was going on in somebody else. And I think that working with couples really helped me get a sense of who I was, which changed my worldview in terms of my relationships with people. And to just expand on that for a minute, one of the things that Yalom talks about in his book, Existential Psychotherapy, is the importance of connection. He spends 200 out of the 500 pages of his textbook talking about connection. And we now know that one of the sort of epidemics that we're experiencing in our modern world is an epidemic of isolation and loneliness and despair. And part of that is how people have sort of lost the capacity to be comfortable in intimate relationships and social relationships, etc. So my work with couples and families has influenced my own capacity, I believe, to be comfortable in more comfortable in social and intimate situations.
Okay, great to know that. Now, Dr. Wiviott, so far, I think in your uh, talks, we got to we got familiarized with a lot of themes of existentialism and existential therapy: connection, connectedness, isolation. Meaning, they came up a lot. Now, if somebody is not familiar with existential philosophy and existentialism, just in few sentences, how do you describe existential philosophy? And then how does it apply into psychiatry and mental health care?
You know, that's such an important question, and it's hard to answer in a few sentences, um, because everybody has a different capacity to think about their own life, and therefore it's an individual issue. If I'm talking to somebody, if for instance, you're not saying, which I thought you might say, but you're not saying if I'm working with a particular patient, how would I introduce these issues? You're talking about somebody, and it may even mean you're talking about medical students. How would I talk to medical students or residents about an existential approach? And I probably would focus on meaning first. How does what, and I would ask them, what is meaningful in your life? And many of the people who are naive about these issues are caught off guard by that. What does it mean, meaning? But that's an introduction to looking at some of the more fundamental issues of what it is to be human. And of course, if we go from meaning, it's easy to go to mortality. Well, how does the idea of mortality play in your daily life, for instance? And they probably will say it doesn't. And I'll say, well, what does that mean if it doesn't? Does it mean that you don't think you're going to die? And we raise the issue of mortality because that becomes so fundamental. It's not morbid. Some people think that, oh my gosh, it's morbid to talk about that. No, it's reality. And I'm not saying that you have to have a particular way of understanding it. If somebody says, I'm going to go to heaven, okay, it's fine. Well, if somebody
Yeah.
says, it terrifies me to think about it,
Mhm.
let's talk about what how that plays in your life. Anyway, these are some of the ways. I wouldn't give a lecture. No, I would rather talk to somebody about how they personally are experiencing these issues.
Okay, great. So is it is it fair to say, in my understanding, that existential philosophy and existentialism looks at the questions of existence for human being, the fundamental questions and uncertainties that a human has because of his condition, the throwness, the Governheit of coming to this earth without knowing where from and where going to. And the relationship with psychiatry is to and mental health care is to look at these themes, the fundamental givens of existence and the fundamental concerns of human being, like meaning, connectedness, isolation, and relationship, and the others that we talked about and we will talk about, and try to find some sort of conflicts in those areas rather than looking at how your parents treated you as a child, or where are the I don't know, the other complexes about suppressed sexual desires. Is that right? Is that a good way to explain it in my simple words?
Another, a very good question, and I'm probably not going to answer it the way you would expect. Those issues that you're talking about are on my mind. They're not necessarily on the patient's mind. And this is going to be a bit of a tangent, but not really. It's the relationship that happens that is an existential relationship. And I think that the work of Martin Buber captures that aspect of it, the I thou I it relationship, or as Walter Kaufman in his translation says, the I you relationship. What they're getting at is the attempt to see a human being as somebody unique and somebody rich with human experiences and human ideas, as opposed to labeling, as opposed to treating a human being as if they were an object who either had a responsibility to fulfill or a an identity which is limited to a particular label. I would rather not think that I'm seeing a depressive or I'm seeing a schizophrenic. I'd like to think I'm seeing a person. And that attitude carries through whether I'm seeing somebody in the emergency room or I'm seeing somebody in my office weekly for a year or two. It's this existential way of not having expectations. I know that sounds a bit crazy, and let me illustrate it with an incident that happened when I was a medical student. Um, Irving Yalom, who wrote the textbook on existential psychotherapy, came to the Allen to give a lecture. And after his lecture, he said, if any residents want to come up and meet with me and have a group, well, he was writing about groups at that point, encounter groups, yes. He said, and want to participate in a group with me, come up to a particular room at 1 o'clock or so, and we'll see what happens. And so 4 or 5 of us went up to the room and we sat in our chairs, and 1 o'clock came and Yalom wasn't there. And so we began talking about, did he forget, and what's going on. Another 5 minutes went by, he still wasn't there. Maybe 8 minutes went by. And finally, he came in and sat down and didn't say anything. And we were getting a bit restless and we didn't know what we were supposed to do. So somebody said, Dr. Yala, what are we supposed to do? And he said, you're doing it. And that struck me as something that was profound. It was so simple. But basically, he said was be in the moment. Don't have expectations about
Hmm.
performance. I don't have expectations for you. And that kind of characterized, and maybe I only recognize that the power of that moment in retrospect. Maybe I didn't appreciate it while it was happening, but it certainly has stayed with me. And so when you talk about um, how I might incorporate an existential approach in meeting somebody, it is that approach. It's not about the content.
Okay, that's great. Now, saying that, what I hear in existentialism and existential therapy a lot is the non-hierarchical and dialogical relationship between the therapist and patient or therapist and client. And as an early career psychiatrist, sometimes it's very difficult for me to imagine that and to think about how I can create such an environment without crossing the boundaries or worrying about, the boundary crossing that might happen. So can you tell to our audience and myself, how does such encounter look like, and how can we create a non-hierarchical, dialogical relationship with our patients?
That is tricky and a great question, and I'll try to do justice to it. One of the opportunities that I've had since I retired, um, actually even a year or so, maybe before I retired, another psychiatrist, a younger young lady, asked me if I would be interested in co-leading a seminar with residents who would be self-selected. It would not be part of the curriculum, and the this meeting that we would have would be monthly, and the theme of it would be called the art of psychotherapy. So I've been doing that for 4 years, meeting with these young residents. I call them young, I mean they're residents. And this theme that you're talking about, this question about hierarchy and flattening the hierarchy and at the same time maintaining the frame. This is how it's been talked about. Has been very important and somewhat difficult. And it's difficult because inexperienced therapists are very concerned about the appropriateness of the meeting and often are happy to be called the psychiatrist, are happy to be called the therapist who are treating a patient, who are happy to be very careful in outlining the frame, which includes the time and the place, and don't ask the therapist questions. I'm not going to answer, and you should, say whatever's on your mind, but I'm not going to say whatever's on my mind. They may not say that overtly, but that's what they're thinking. And a lot of it is because they're so afraid of boundary crossings. They're so afraid of inappropriate interactions. They're so afraid of being accused by their supervisor of doing something that's not appropriate. So as soon as you talk about, or as soon as I talk to these residents about flattening the hierarchy, it arouses anxiety. And one of the first things they would say is, well, what's the difference between what you're describing and a friendship? You're talking about that you, the therapist, are free to reveal, talk if the certainly if the patient asks you questions. Whereas in the classical psychoanalytic model, if a patient says to the therapist, "Oh, you're going away for 2 weeks. Where are you going?" The analyst oriented therapist is going to say, "Well, where do you think I'm going to go, or what are your fantasies, or something like that." Whereas the kind of therapy that I'm talking about, the therapist may say, I'm going to a conference in California, or I'm going to whatever, not being afraid to be human and to be real. That's, in a way, that's what Eric Whitcower, the psychiatrist that I told you about, who said to me that I should tell my patients that I like her. That was shocking to me. Well, now I can say that to people who I supervise, and or in the seminar, for instance, that you can reveal things if you think it's going to be helpful. You can reveal things, not inappropriately. It's not your therapy after all. But
Mhm.
if it helps the relationship, and if it helps the patient feel more comfortable in a real relationship as opposed to the hierarchical therapy relationship, then it's very, very useful. But at the same time, I have to emphasize that there is a frame, and there's several elements. The frame is we meet at a certain time and we end at a certain time after so many minutes. The frequency of our meetings is such that we can plan it, that we'll meet once a week or every 2 weeks. I also say to patients, and this also was something that when I was a resident we didn't do. I also give patients my email, or because we didn't have email when I was a resident, fair enough, but or phone numbers for that matter. And patients don't abuse it. They don't abuse it, but they feel better knowing that if something comes up, they can get in touch with me. Yes, that's important. And I'll say that. Is that part of the frame? Well, it's part of the frame that I'm constructing. And another part of the frame, particularly for psychiatrists who are in practice, is you're getting paid for it. Hopefully, you're not doing it because you're getting paid for it, but that's part of the frame. It keeps things clear that there is a difference between the person who's seeking help and the person who's offering help. That should not be blurred, even though it's a less hierarchical relationship.
Okay, thank you for clarifying this. I think it's very helpful to consider that there's still a frame, but the frame is more in existential manner. Now, speaking of residents and training programs, how much do you think psychiatry residencies, the ones that you are familiar with, they teach about existentialism and existential therapy? And do you think there should be more of it, and if yes, how can it be done?
You know, I can get very depressed talking about this. Um, so Tanya Luhrmann, um, I think she was a sociologist, wrote a book called Of Two Minds. And what Tanya Luhrmann did was go, I think, to the University of Texas and spent the time with residents who are going through their training program for 4 years. And she was documenting how much time is spent on psychopharmacology or the sciences and how much time was spent in the more social or psychological aspect of psychiatry. And she said it was, when she did it, it was 75% psychopharmacology basically and 25% psychotherapy. And then she went back a year later, maybe it was 2 years later. This was in the early 2000s. And she, again, this time spent a year with the residents. And she said it has changed. It's now 90% psychopharm and 10% psychotherapy. And I've heard that about other training programs. I know people who've been in other training programs, particularly University of Toronto, which has become very, very psychopharmacologically and neuropsychologically oriented. Much less time in psychotherapy. And in fact, one of the things I heard, and I can't validate this, but one of the things I heard was that in psychiatry, they say, yes, psychotherapy is important, but let the psychologists or the social workers do it. That's not what psychiatrists are for. And therefore, their training program is obviously skewed in that direction. As I said at the very beginning of our talk, when I came to McGill in the 70s, there was this great, wonderful interaction, maybe even competition between the analysts, the behaviorists, and the pharmacologists. And for sure that now I think that the residents are getting much more training in DSM-5 because that's what they're examined on when they have their Royal College examination. They're being asked questions which primarily deal with diagnosis and treatment, pharmacological treatment, and there's much less emphasis or even curiosity about their training in psychotherapy. So Why do I think it's important to bring an existential orientation? I'm not going to say therapy to the training, although it's useful. I think it certainly was useful for me to supervise residents. And in my supervision, we would look at it from an existential point of view. But an existential orientation is even important if people are doing emergency room work. If they're doing CL work and they're dealing with people who are in the hospital because of severe physical problems. These are people who are dealing with life and death issues, and an existential orientation is very helpful in being receptive to the needs of these patients.
And Dr. Vivian, can you describe existential orientation for us? How can a psychiatrist or a physician, healthcare provider of any sort who is not doing existential therapy per se have existential orientation and approach to the patients?
The first, I'm going to free associate. The first is not having expectations about what the patient
Hmm.
should be doing or saying. The second is not labeling, not resisting the need to label. And the third, and this is really hard, is resist the um, the impulse to speak. Okay, why am I talking about the impulse to speak? Because I value listening. And I
Hmm.
don't care if you're doing a 30-minute assessment of a patient lying in a bed on an oncology service, or you're seeing somebody in your office. If you can allow the person to feel that you are only interested in them with a certain kind of curiosity and a certain kind of compassion and the capacity to let them know that you're trying to be with them, that's an existential orientation. It doesn't have the expectations to uncover the roots of the problem. It doesn't have the expectation that by mental status questions, you're going to figure out the diagnosis. These will happen. You will be able to make a diagnosis. It'll come up, but it ought not to be the first way in which you approach a patient. What I'm talking about is that sense that the patient feels that you're there to understand them as opposed to classify them. That's it.
Okay.
I'll emphasize the point. And that's true whether you're working in a mood and affective order clinic or a borderline personality clinic, or if you're doing CL work on the trauma service.
Okay. Now, going back to the previous question and conversation about residents, I'd like to share a little bit about my experience when I was psychiatry resident. I, I think I'm McGill. We had quite good psychotherapy training compared to a lot of other programs that I know, but not much about existential therapy. We had one session with you, and I remember you came to the class and said that if you want to remember something from this session is Irving Yalom and meaning. There were two things that you said. Now, when I got interested into existential psychotherapy and existentialism in terms of philosophy of life and practice, I thought that I lack the knowledge and the kind of guidance how to go, where to go. There are a lot of books out there. So I I remembered you and I contacted you and I said that can you please supervise me or mentor me in this journey? And you kindly accepted despite the fact that you were about to retire around the same time I emailed you. Now, I want you to talk to our audience a little bit about the role of supervision, mentorship, not only for trainees and residents, but also for maybe independent psychiatrists, psychologists who are practicing, but they want to delve more into existentialism.
Um, you know, I talked about couple therapy and the triangle. There is a triangle in supervision also. The triangle is me and the supervisee and the patient. That's the second side of the triangle. And the third side of the triangle is me and the patient. Now, obviously, I'm not seeing the patient. I'm hearing the patient through your or through the supervisee's eyes and ears. But that doesn't mean that I don't have a relationship with the patient. And in the context of that supervisee patient supervisor triangle, I'm trying to understand the issues that are being expressed both by the supervisee and by the patient, and how I can be helpful in the, to use couple therapy, in the relationship between the supervisee and the patient. However, in order to do that, I have to think about the relationship that I have with the supervisee. And I have to think about how are they expressing the issues that you and I have talked about today? How are they resisting the impulse to talk? How are they resisting the impulse to maintain the hierarchy? How are they experiencing their own notions of mortality and meaning and freedom for that and choice in because that's what the patient seems to be expressing in my relationship with the patient. This is what I'm hearing when I'm imagining what the patient is going through. These are issues that I'm thinking that the patient is dealing with. Therefore, I have to say to the supervisee, is that something that you're aware of? Well, let's talk about that. Why is it that I'm picking that up and I don't you're saying that that hasn't been important for you. Let's talk about that. So in a way, in a way, supervision is also a kind of relationship which has similarities to a therapy relationship.
That's great to know. Now, going back to existential orientation, you said that it can be used in any setting, any patients, and any therapeutic relationship. But speaking more about existential therapy and the other therapies that are derived from existential therapy, do you think there are certain mental health conditions that can respond better to existential therapy, or it's still like existential orientation applies to all mental health conditions in terms of treatment?
Okay. So if I talk about pure existential therapy, looking at the content and some aspects of the relationship, I would say probably it's limited to people who are more capable of psychological thinking, more capable of hearing about a different way of understanding lived experience, and maybe that could apply to their experience. And some people can't. I accept that. That's the limited way of understanding an existential orientation. But if we broaden it, and here's one, I have to confess my own conflict. My own conflict is how do I integrate self-psychology with an existential approach? If we can re somewhat reductionistic say that an existential approach allows a kind of authenticity between for the therapist to be more authentic and say what he or she is thinking or expressing what he or she is feeling. A self-psychological approach looks at empathy in a different way. It looks at empathy as a clue to what the patient needs from the therapist, particularly earlier on in therapy. So the patient needs a therapist to mirror their quote grandiosity, these are Kohut's term, or to be available for an idealizing relationship that the patient wants with the therapist. Okay, so now we get back into any patient. And I'm going to say that any patient can be appropriate if I look at an existential approach incorporating the self-psychology notion of empathy. By that I mean, and I have to give you at least an example. A patient is, I'm asked to see a patient who's very angry. And the consult says, can you recommend a medication for this patient who is always angry and is shouting and whatever? And I believe that this is an example of an empathic failure, that for whatever reason, this patient is angry because they feel that they're not being understood. And if I can bring some kind of empathic attunement, then I might think that what this patient needs is to feel understood as opposed to being sedated, tranquilized, or given some other kind of medication. If I can let the patient know that I'm not there to judge, I'm not telling them to calm down, but I'm there to understand what they're going through, that very often is much more helpful than immediately reflexively writing a prescription. That's what I mean, that almost any patient can benefit from that, certainly in earlier interactions. But the formal existential therapy, where we're dealing with mortality and freedom, for some people, those are really, frightening issues. We're just not going to get very far. If a patient comes in who feels that they're the victim of life experiences, and I try to talk to them about the fact that they have choices and they don't see that, I'm not going to get very far with them. But with many people, it's very useful to offer them the possibility that they have choices and they can make them, and they're responsible for the choices they make.
Okay, thank you. Now, Dr. Wiviott, I want to use our last few minutes a little bit as learning for myself and also introducing the concept we talked about that I'm working on. Before delving into existential psychotherapy, I was working with Dr. Danius Puras in human rights in psychiatry. And human rights in psychiatry was focusing on dignity, autonomy, participation, non-discrimination. Then I learned about existential psychotherapy with you and my own readings. And there were some similar themes, like freedom, choice, responsibilities, very much similar to autonomy, meaning and
Yes.
purpose, very much similar. So I thought about introducing a new concept to psychiatry. I talked about that with you, which was right-based existential psychiatry. And I said that use the common areas of human rights and existentialism to introduce a new way of looking at mental health conditions and a therapy model, which is kind of consistent with this framework, deep therapy, dynamic, eclectic, existential psychopharmacotherapy. And I briefly tell about to the audience that are not familiar, it has 7 modules of acceptance, behavioral change, cognitive restructuring, dynamic analysis, existential exploration, which is the main theme, existential exploration, and focused pharmacotherapy, because as a psychiatrist, I believe in medication and medication effectiveness in mental health conditions. And finally, grounding techniques. So A, B, C, D, E, F, G, the 7 modules. We talked about that. Now, I want to know your uh, thoughts and feedback, and I want our audience here about how do you see this concept or new concepts like this, integrative and patient-centered concepts, uh, evolving the existential approaches in psychiatry?
Martin, let me first of all say that I read um, a paper that you wrote talking about deep DEEP therapy, and I have to compliment you on that paper. It's quite a wonderful read. So I read it with the idea that you're letting me in on this because of the existential aspect of it, which I see all through the paper. Certainly the stress in terms of human rights on autonomy and avoiding coercion, whether it's coercion to take medication or coercion to be admitted to the hospital, um, for sure, this is important, stressing autonomy. It's also important, I think, to recognize that patients do have some responsibility in terms of the care that they're getting. They have choices, and we need to respect that. Um, the the clinical situation that came to my mind, since I'm not doing human rights work as you are, or culturally sensitive work, which you are, but I certainly have had opportunities to have people, uh, to treat people, not have isn't the right way. I was going to say have people in my office, but it also can be on a ward or whatever, who need medication. However, I believe whether you're giving somebody a antipsychotic or you're giving somebody an antidepressant, it's in the context of the relationship of the patient and the prescriber. And that is at least 50% of the benefit of the pharmacological approach, at least 50%. And therefore, I'm saying that the way I'm describing an existential orientation in terms of the relationship applies perfectly with the role of a psychopharmacologically oriented psychiatrist working with a patient. If that person, who certainly has an expertise in pharmacology, can at the same time look at the patient, have enough of a time, and it doesn't take more than 10 or 15 minutes, to let the patient know that the psychiatrist is interested in what and who they are and what they're going through, not just a systematic list of symptoms and side effects. That would be so important. And that's when I was working with residents, certainly that's one of the things that I was trying to bring to their attention.
Okay, great. Thank you so much, Dr. Wiviott, for your time. Now, I want to summarize my take-home message from our today's conversation that, as a mental health professional or health professional dealing with patients, it's important to have existential orientation and existential exploration. And that technically means to to give more value to a relationship which is dialogical, non-hierarchical, to focus on here and now with the patient during your session, and not to be shy to explore more about the meaning or the fears and worries of mortality and death with your patient, to make them aware of their freedom, choices, and consequences of their choices, and as a journey traveler to discuss the meaning of life, purpose in life, and the things that comes related to isolation, connectedness, and authenticity. So I think that's a lot of things for me and for the audience. Would you like to also give us a final message or take-home message for the audience?
Well, I was listening to your summary, which I think, wrapped it up quite nicely. But I do want to make one comment about that, and that is your comment about the here and now. I don't think of, I'm not into mindfulness. I'm not into focusing on what's going on immediately. I like to think about what's going on. But if the patient, client, person in front of me wants to talk about events in their life, I'm listening. I'm not going to say that's not important. What do you feel here? No, I'm not into. I'm aware of it, but I hope that people are free, feel free to talk about things that are important to them. I might put it in my own mind into some kind of existential framework, but I'm not expecting them to. That's the only comment I'm going to make about the here and now. Though all the other things that you said in your summary, I thought were beautifully stated. Thank you. I didn't think I was that clear.
Okay, thank you so much, Dr. Vivian. It's great to have you.
Okay, good. I'm happy to be here.